I would first like to welcome Deepti Gupta. Dr. Gupta is a triple board certified in pediatrics, dermatology, and pediatric dermatology. She has been practicing for 9 years and has an interest in equity, diversity, and inclusion, along with increasing access to care and clinical pediatric vascular abnormalities, pigmented lesions, and telehealth. And with that, Deepti, we are ready for you to begin.
Thank you so much for having me this morning, and I apologize for my voice. It might crack in a little bit here and there, so if there's any questions, please feel free to put them in the chat, and I'll answer them as well. So today we're going to be talking about just some potpourri, kind of a little bit of a smorgasbord of pediatric derm issues, things that you may see in the clinic, in your own practices, in the hospital, and maybe in your own lives as well. So without further ado, we'll go ahead and get started. I don't have any relevant conflicts of interest. So today we're going to kind of open that book of pediatric dermatology and kind of hone in on 3 kind of main chapters. So the first one's called Bottoms Up. So this is a 10-month-old female who presents with a persistent diaper rash. Parents kind of come in because the rash is spreading. It doesn't seem to bother her very much. And she's tried clotrimazole, hydrocortisone, zinc oxide, and nothing really seems to be helping. And so what you see here is this actually fairly well demarcated kind of erythematous plaque that's involving pretty much all of the diaper area. So it's going up onto the mid-abdomen, and also scattered little papules and plaques on the abdomen, on the inner legs, and it's involving the creases, the inguinal folds, as well as the whole kind of diaper area. So if you guys look at this rash, is there any things that you guys would be thinking that this might be, some diagnoses that might come to mind? You can put those in the chat if you feel kind of wanting to put one of these letters in of what you might be thinking. And so I'm seeing some answers for a candidal rash, a lot of thoughts about candidal rashes here, and contact derm as well. So this is actually psoriasis. And the reason I wanted to show this case is that in the diaper area, when we see a rash, it all looks kind of very similar, but I wanted to hone in on a couple of morphologic keys that will help you distinguish between all these different rashes. So psoriasis is also called napkin psoriasis in the diaper area. It's a really well demarcated rash. And the reason that it might come up for some individuals is because there's a Kebner phenomena, meaning that the rash goes in the path of least resistance. So because of friction, the environment being moist, stool and urine getting in this area, the psoriasis can kind of hone into that area, and it's really sharp. So even in this picture, you can see how sharp it is. You know where it ends and where it stops, and you don't see any of these satellite lesions, these tiny little circular lesions, which give us more of a hint of candidal rash. And so it's very sharp. It involves the folds, and it oftentimes is really stubborn and hard to treat. There also sometimes can be some scaling on top of the rash as well. And then you might see other areas involved too. So psoriasis sometimes doesn't just hone into the diaper area, but you can sometimes see these well demarcated plaques and papules also on the abdomen and on other areas of the body. And so really to treat this rash, we want to decrease the friction and trauma to this area. So good barrier protection. So you're going to be using your zinc oxide, your Aquaphor, your Vaseline, but you also need a topical anti-inflammatory. So a little higher strength topical corticosteroid and calcineurin inhibitors, which have no steroid in them, and using those regularly for this type of rash is important. And individuals that have psoriasis in the diaper area, sometimes they have psoriasis later on in life as well, and sometimes that can be predicted by if they have a first-degree family member involved or more areas involved than just the diaper area. And then I wanted to highlight atopic dermatitis. So eczema, atopic dermatitis is very common, but it actually spares the diaper area. And you might also see this very characteristic sign. We call it the headlight sign, and it's also sparing of the nasal tip. Does anybody know why atopic dermatitis might spare the diaper area or the nasal tip? It's because those areas, a couple of comments about being maybe more mucous membrane areas and moisture. And moisture is actually the right answer. The diaper area is kind of this moist tropical environment, and so oftentimes um, that area, atopic dermatitis, is not present in the diaper area. And actually, the nasal tip has tons of sebaceous glands, tons of oil glands. And so that is actually one area that's really spared. So whenever you see a patient with atopic dermatitis, you will see that that nasal tip is spared and the diaper area is also spared. And there's a question in the chat about tacrolimus is a type of calcineurin inhibitor. That's correct. And then I wanted to bring your attention to seborrheic dermatitis. So this is a rash that you'll see in the folds and also classic areas for infants. And what we can see here is just a lot of kind of erythema within those folds. And then you might find other clues other places. So the classic cradle cap for seborrheic dermatitis, that yellow, greasy scale that happens in the scalp, but then also in the eyebrows, the glabella. And then you might also see it in other intertriginous areas, this kind of pink-red erythematous patch that can happen in all the folds. And what seborrheic dermatitis is has a lot of, what the driving force of this condition is actually a yeast, Malassezia furfur, or Pittosporum ovale, as it's called now. And that yeast gets in all the folds. It makes it proliferates in that moist environment, and it causes a dermatitis, a rash, and that's why it's centered in the folds. That same yeast also loves oil. It loves oily areas, and we have the most oil glands on our scalp and face. And so that's why you're seeing seborrheic dermatitis in all these very oil-rich areas, such as the glabella, the forehead, the scalp, and then also the kind of folds as well. What we would do here to treat this is, again, good barrier protection, but also a little bit of low-dose topical steroid like hydrocortisone, 1% or 2.5%, and a little bit of anti-yeast medicines such as clotrimazole as well. And then I wanted to highlight candidal diaper dermatitis because oftentimes when we look in the diaper area, we always think it's got to be candidal. And I see a lot of patients referred who've been using anti-yeast medicines, and sometimes it doesn't help because maybe it's not a candidal diaper dermatitis, as we just saw. And so for Candida, the key feature are these tiny little erythematous papules and sometimes even pinpoint pustules that you'll see all throughout the rash, and those are representative of yeast. You'll also see Candida in the folds, and that's because yeast loves to proliferate in those moist folds. And so this patient has kind of classic candidal diaper dermatitis in the folds and those tiny little satellite lesions, those little pustules and papules. Here's a couple other pictures of it, again, highlighting those satellite papules and pustules, and also that involvement of the folds. And here's another patient as well. And then I wanted to highlight irritant dermatitis. This is probably one of the most common diaper dermatitis things that I see, not only in clinic, but also in the hospital. And it's really secondary to the skin constantly being bathed with stool and urine. And what you'll see is you'll actually see sparing of the folds. Does anybody know why it might spare the folds in an irritant dermatitis? Well, if you can imagine, and so there's a couple things protected from moisture. So when a baby might be laying or kind of just their natural position is actually to occlude those folds, to protect those folds, the two sides of the thigh and the lateral part of the perineum. They're going to kind of come together and they're going to protect the fold area. And so stool and urine is oftentimes not going to be getting into those folds. And so therefore, irritant dermatitis actually spares the folds, which is different than candida or seborrheic dermatitis, where the yeast really loves the moisture-rich areas and proliferates in those areas. Here we're also seeing that the irritant dermatitis is more not only sparing the folds, but also in those contact areas. So the labia majora is contacting the front of the diaper where there could be urine and stool. And then we oftentimes see it on the medial buttocks as well, wherever there is direct contact with the irritants. This is what an individual a baby can look like from the backside. So with the irritant dermatitis, all that area that's being contacted by stool or urine or even the diaper itself can cause the rash. And then this is just to highlight that kind of sharp sparing of the folds and then everything else being involved. When an irritant dermatitis gets really severe, you can actually get this erosive irritant dermatitis called Jacquet's. We get a lot of consults in the hospital for Jacquet's erosive dermatitis. Oftentimes, this can be mistaken sometimes for a viral infection like HSV. And when it's really severe, you can get these kind of punched out lesions of erosion and ulceration just because the skin is constantly being bathed with urine and stool. We oftentimes see patients with like stool leaking syndromes, short gut syndrome, where they're having maybe a lot of diarrhea. And the skin can't be protected from the constant irritation of the stool. And so that breaks down the skin. And the way that we would treat this is barrier. So a really good barrier, such as zinc oxide, something that's thick. One thing to know about zinc oxide is that it's really sticky. You don't want to rub it off. You want to take it off either with mineral oil or a little bit of a warm bath or washcloth, and try not to rub zinc oxide off because it will irritate the skin more. Usually what I would do is zinc oxide in the morning after the area has been cleaned, and then I do sometimes use a combination of a topical steroid, a topical antibiotic, and a topical anti-yeast medicine. I'd put that directly on the skin, the zinc oxide barrier on top, and then with every diaper change, I'm using Aquaphor or Vaseline or vitamin A and D ointment to keep adding the barrier onto the skin so that the stool and urine is not getting onto the skin and causing further irritation. And then I just wanted to highlight this is more of a rare entity, but after you've seen all of those other diaper dermatitis, you've seen atopic dermatitis, which does not affect the diaper area. You've seen well-demarcated psoriasis. You've seen candida and seborrheic dermatitis that likes that moist intertriginous fold area, and irritant dermatitis that spares the folds. This has a little different morphology, and what you might see is some people might describe this as peeling paint, and the color is kind of this red-brown, and you're seeing that around the perioral area and around the diaper area. And that peeling paint kind of look, the well demarcation, the color, red-brown kind of color, is actually something we see for zinc deficiency. So we see this in babies that are being weaned from, or breastfed babies, or babies that have cystic fibrosis or other nutritional deficiencies. This is one way that zinc deficiency can present with a chronic diaper dermatitis that has a kind of a peeling paint kind of look, that red-brown look, and looks a little different from the other diaper dermatitis that we just saw. So the patient that we saw had psoriasis, that well-demarcated rash, these well-demarcated erythematous papules and plaques in other parts of the body as well. All right. So now we're going to just change gears to our second chapter of this book, The Itch That Scratches. So this is a 12-month-old female who comes in with this persistent rash around the mouth. And you can see here this kind of slightly ill-defined erythematous kind of thin plaques that involve the cheeks, the chin, the perioral region. It spares that nasal tip and the upper cheeks. And then she also has this kind of ill-defined erythematous kind of patches on her anterior chest as well. Parents state that it's really itchy. She's not sleeping well at night. They've been using lavender lotion and hydrocortisone cream and really have not had much response. There's a family history of asthma and allergies, and they bring her in today to kind of get her better relief from this rash because she's not sleeping and they're not either. So, any thoughts about what this might be? So, could this be psoriasis? And there's a question, is this only on the face or anywhere else? And we can see on the picture, a little bit on the anterior chest. This patient also has it on the extensor surfaces of the arms and legs. And so I see a lot of responses for atopic dermatitis, some saying staph infection as well, contact dermatitis from food, all great responses. Thank you so much. And this patient actually has atopic dermatitis. And the couple key features of this are it's not so sharp as psoriasis in our last photo. It's ill-defined. It's around the mouth. It spares that nasal tip. And you can't really see where it starts and stops. And so this patient has atopic dermatitis. Atopic dermatitis is an inflammatory skin condition, very, very common. Most kids develop atopic dermatitis by 5 years of age, and it kind of changes its distribution over time. So in the less than 2 age group, what we see is that atopic dermatitis, again, follows the path of least resistance. And so if there's friction somewhere or trauma, we see atopic dermatitis honing in there. And so in our infants, we see a lot more atopic dermatitis around the face where there's saliva and drool. We sometimes see it in the scalp where there's seborrheic dermatitis. And we see it on the extensor surfaces because infants are starting to get up on their forearms, they're starting to crawl. And so you'll see it on the knees, you'll see it on the elbows. And that's the more classic presentations of atopic dermatitis in the less than 2 age group. And then as we get older, in older kids, we start to see more of that classic kind of description of atopic dermatitis, which is inside the creases. So the flexural areas of the neck, the elbows, the knees, the wrists. They're also doing a lot more maybe hand washing or play with different materials. And so we'll see atopic dermatitis on the dorsal hands, the wrists as well. And atopic dermatitis can be quite frustrating in that it's a chronic condition. It comes and goes. And oftentimes we see it in conjunction with other atopic entities such as seasonal allergies, asthma, allergic rhinitis. And this is kind of the way that we can see it. We can see these ill-defined kind of erythematous plaques. There's lots of excoriation. And then here you're seeing those increased skin tension lines. They're really more prominent, and that's a little bit of lichenification that we can see. Here's a less than 2-year-old, a little toddler who presents with atopic dermatitis. Again, that facial predominance, it's ill-defined, nasal tip sparing. And then on the extremities as well, we see sometimes these coin-shaped or nummular areas of atopic dermatitis. And then as children get older, we see that flexural area, the antecubital fossa, the popliteal fossa. Atopic dermatitis, again, really ill-defined. You don't know where it starts and stops. It's really itchy, so you see excoriations in these areas as well. And the reason that individuals have atopic dermatitis is that their skin barrier is actually really disrupted. I think about the skin barrier like a brick wall, and you have the bricks and you have the paste in between them. And that paste is really not there in patients with atopic dermatitis. And so water is constantly coming out. excuse excuse me. And so we're seeing that that barrier is disrupted. Water is constantly leaving the skin, and so we have to add that water back in the form of emollients. When the barrier just is disrupted, not only can water get out, but we also see bacteria, allergens, viruses get into the skin and infect the skin. So what triggers atopic dermatitis? Well, pretty much a lot of different things. I have patients come in and ask, what can we do to prevent this from happening? And the key is repairing the barrier, and they're oftentimes asking what is causing it, and it's not really one thing. There's a disrupted skin barrier with dry skin. There's irritants and allergens that are getting into the skin. There's changes in weather and environmental changes. We've had a lot more smoke from wildfires in the summer. That affects my patients with atopic dermatitis. Pollution, we see definitely higher rates of atopic dermatitis near airports, where there's more pollution from airplanes, and in the city. Infections, viral infections, and also bacterial infections. And then itching and scratching keeps propagating atopic dermatitis, as well as stress, which can be stress on the body, emotional stress, infections. Kids get sick, oftentimes atopic dermatitis flares. So many different factors that can all lead to triggering atopic dermatitis. So how do we manage atopic dermatitis? And there's really 5 main pillars that I think about to treat atopic dermatitis. And one is repairing that skin barrier. And by doing good emollients and good care, controlling the inflammation, treating any infection that's present, using antihistamines to break that itch scratch cycle, and then really understanding the social determinants of health for patients. Many of my patients, we might say, use an emollient like Aquaphor or Vaseline, and that's just maybe not affordable for them. Some patients can't get to visits, they don't have internet to do telehealth, they may have transportation issues. And then there also might be cultural practices and thoughts that we have to kind of unfold to help treat atopic dermatitis more effectively. Really addressing all of these all at once and treating all of these things all at once is really going to give us the best outcomes for atopic dermatitis. Sometimes if patients just do one thing, such as maybe the emollients, but they're not really controlling the itch or the infection, atopic dermatitis is not going to get better. So I'll just briefly go through these key factors. So gentle skincare, what that means is using products without perfumes, without dyes, and using an emollient that they can use twice a day, at least to the skin, to hydrate the skin. I get a lot of questions around bathing. Okay to bathe every single day, and sometimes in patients with atopic dermatitis, it's actually recommended because they can get all those allergens and irritants off their skin. The bathing will hydrate the skin in the moment, but the key is that you need to seal in that moisture with the emollients right after bathing. If you let the skin dry, just air dry, then you're going to allow the skin to dry out. So bathing is okay every day, but just seal in that moisture right after the bath, and also using mild soaps, not necessarily antibacterial soaps, and only using soaps in the areas that get most dirty, which are really the diaper area for infants, and maybe older kids, maybe the underarms and the genital location. You don't need to necessarily lather the whole body with soap. Soap does strip the skin of its natural oils, and using soaps without any perfumes or dyes. I get a lot of questions about natural emollients. And again, no perfumes, no dyes, no essential oils. Those can all be irritating to the skin. Um, Sunflower oil and coconut oil actually have the right medium chain fatty acids that absorb well into the skin, so they're not a bad option. So if patients want more of these natural emollients than sunflower, safflower oil, coconut oil, shea butter unscented, things not to use, olive oil. And the reason for that is that olive oil actually does not have the right fatty chain acids and can actually be irritating to the skin. And for seborrheic dermatitis, cradle cap, it can actually propagate the Pittosporum ovale or the malassezia that drives that process. So you don't want to use olive oil for that reason as well. And beware of these products degrading and contamination. I tell all my patients no double dipping. So if you have a big jar of emollient, you don't want to dip in the emollient, put it on the patient's skin, and then take that same hand and put it back into the jar, because the patient's skin probably has a lot of bacteria on it, and now you've kind of contaminated your emollient. So something that seems counterintuitive, but just good to mention as well. So that's kind of the basics of the skincare, and that's routine for patients. It's part of their maintenance, and something that I try to get patients to do early on, so that they can kind of continue to do that in their teenage years and their young adulthood. The other mainstay of managing atopic dermatitis is really controlling the inflammation. And the first line is topical steroids. Topical steroids don't really have the same side effects as oral steroids or inhaled steroids. They're put directly on the skin, and they're a great way, skin-directed therapy of controlling that inflammation. When you're choosing a steroid, think about what part of the body you're using it on, because there's areas that are thinner skinned, like the genital area and the eyelids and the face. You're going to use a lower potency topical steroid. Areas of occlusion, such as the armpits, that might not need as high of a topical corticosteroid strength. And then steroids come in ointments, creams, lotions, oils. Ointments are going to be the most hydrating and actually absorb into the skin the best. This is just, you have this in your handout, I believe, as well, but just they come in all different strengths. Hydrocortisone over the counter is our lowest strength topical steroid. Clobetasol is our highest. And when you're picking something, think about, is this a hair-bearing area? Then I might use an oil or solution. And in general, trying to use ointments. And they're the best as far as getting the medicine to where it needs to go. One thing to note is 1 fingertip unit is equivalent to half a gram and 1% body surface area. So a half a gram will treat 1 palm size area twice a day for a patient. So if they have a lot of area involved, they're going to need a lot more medicine to be able to treat that area. And then after controlling the inflammation, patients with eczema are much more prone to infection. And this next section, I want you to be able to identify some ways infection looks on the skin, and then also kind of some tools to prevent infection as well as treat infection. So this is a way that a bacterial infection may present on the skin. And what you're seeing is increased kind of erythema of that eczematous area, but then also this honey-colored crusted area. The rash is very oozy, which is different from, if we look back at this area, see how dry this area is erythematous, but it's also very, very dry, and that's how eczema oftentimes presents. But when it gets infected, it starts to get really weepy, really oozy. You get that impetiginization, that honey-colored crust, and patients with eczema get much more itchy when they get infected. This is a patient with eczema on the back of their leg. You can see that kind of thick, honey-colored, kind of oozy crust, and then the increased erythema of the area as well. And then you can also start to get these like punched out little erosions And sometimes you might see pustules and even kind of expanding erythema and cellulitis as signs of infection. So when you're seeing infection, swab the area, and then thinking about treating it with oral antibiotics. What we know about patients with eczema is that if you swab their normal skin, they actually are colonized with bacteria that's just waiting for an open area to be able to infect. And so it's important to have patients with eczema try to treat their eczema, treat their skin barrier defect. And in about 80% of patients with eczema, they have that bacteria just on their skin, and that's compared to about 10% of patients who do not have eczema. So definitely a much higher rate of their skin being kind of sticky and kind of having bacteria kind of always there. Um, so I would, if they do have those signs of that weepy, oozy impetiginization, I would treat with oral antibiotics. Topical antibiotics sometimes cannot be as helpful. And then I'd really look at prevention strategies. So not only repairing the barrier, treating the atopic dermatitis, but one thing that I love is dilute bleach baths. I don't know if anybody has used dilute bleach baths or dilute bleach bath spray, but it's great to prevent infection, not only in our patients with atopic dermatitis, but patients that have recurrent abscesses, student athletes that are around a lot of bacteria, patients that are immunocompromised, have central lines. It really decreases bacterial infection. There's also an over-the-counter called CLN Wash that can also be very helpful. It has sodium hypochlorite, which is bleach, diluted in the wash itself. It's a little bit more elegant of a product and easier for like our older and teenage patients to use. So this is kind of the instructions about the dilute bleach bath. It's about a quarter cup of bleach to a full bathtub of water, so 40 gallons. It's also equivalent to about 1 teaspoon to a gallon of water. In my teenage patients, we sometimes make a dilute bleach bath spray that they can spray themselves with in the shower, or if they're taking a bath still, they can do this 1 to 3 times a week. Bleach actually has anti-inflammatory properties, and so it can actually treat some eczema as well as be an antimicrobial. So it's really a wonderful tool, an easy tool. Just have to go through with patients that it is dilute bleach bath. They're not putting, household Clorox bleach fully into the bathtub. It's really diluted out, and it's pretty inexpensive for patients, and has a lot of wonderful uses. Again, great to prevent superinfection. If you have recurrent abscesses, atopic derm, immunocompromised patients, high risk populations for infection, this is a wonderful preventative tool. And then I just wanted to highlight a couple other viral infections that patients with atopic dermatitis can get. So this is a patient that came into my clinic. You can see in these areas where atopic dermatitis may be more present, like the popliteal fossa, there's numerous punched out erosions all throughout the torso as well. And this is eczema coxsackicum. So Coxsackie virus, the hand, foot, and mouth virus, can actually infect patients with atopic dermatitis. And wherever their atopic dermatitis is, that Coxsackie virus can kind of hone into those areas and flare the eczema and make these small little punched out kind of lesions. It's oftentimes kind of confused for eczema herpeticum, the herpes virus. But some things that you might see in addition to the rash is they might get these large bulla or vesicles on the hands, the feet. There's a new strain of Coxsackie virus that actually makes these large bulla, as you're seeing in the upper right corner, on the hands and feet, rather than the more typical vesicles that we can see with the typical hand, foot, and mouth virus. So this new strain A6 can make these really large bulla, and you might see these large bulla on the hands and feet, on the palmar surfaces, the plantar surfaces. You might see perioral papules and vesicles, and then if you look inside the mouth, you might see some herpangina, some erythema, and of the posterior kind of oropharynx and the soft palate. in addition to the rash. This is what typical hand, foot, and mouth looks like. And we describe these as football-shaped little vesicles that happen on the palms. You can see those little vesicles on the buccal mucosa and on the soft palate as well. Um, this is very painful, and a lot of times you'll see kids in the clinic like really uncomfortable with their hands and feet. It's just painful, itchy. I don't know if anyone's had hand, foot, and mouth themselves, but the new strain infects adults as well, and so we're seeing a lot more healthcare providers, teachers, parents get hand, foot, and mouth as well. And one kind of cool fact about hand, foot, and mouth is that the nail plates can shed about 4 to 6 weeks after the viral infection. And so this is a patient of mine that came in with their nails in a little baggie, and they had hand, foot, and mouth about a month ago. The nails come back normally, but it can be kind of distressing to patients and families when their nails shed. This is a patient with eczema herpeticum and has the herpes virus infecting anywhere that there's eczema. Again, we talked about that barrier being disrupted, and so the virus can get into anywhere that there is eczema, and they get these really kind of what we call monomorphic, punched out lesions and vesicles with a lot of crusting as well. Another virus that patients with eczema can get a lot more of is warts. And I want to hone you in. Warts can sometimes be mistaken for calluses. This is a great example of a wart in the upper right-hand corner. What you see is these little black dots. Those are actually little capillaries that have become thrombosed, and the wart virus recruits a lot more capillaries to keep itself going, and then those capillaries form thrombi. And so if you look really closely at warts, you'll see them studded with these little black dots, and that's because those are the capillaries that the virus has recruited. You'll also see interruption of skin tension lines. So if you look at your own hand, you'll see all these tiny, tiny, fine little lines, and those are skin tension lines. And when you have a wart, those skin tension lines are interrupted. And so you can see that here, all those fine skin tension lines, and then the wart happens. That does not happen in a callus, which is just an increase of skin on that's kind of heaped up due to friction. Those skin tension lines are preserved. In this picture on the left, you see a patient with eczema and just a lot more warts because the barrier of the skin's disrupted, the virus gets in, and the warts go rampant. And then this is another viral infection. Anybody know what this might be? The way I would describe it is these kind of circular, pearly papules that are clustered here on the buttock and here on the popliteal fossa. And if you look real close, they can be kind of umbilicated or have a little white core. So yeah, lots of great answers in the chat. So yeah, this is molluscum. Molluscum is caused by the pox virus, the same virus that different strain of it that causes smallpox. And it's probably one thing that we see a lot in dermatology clinic and is very frustrating. And the molluscum can actually make its own dermatitis. So this is a patient with molluscum lesions, all scattered. And then there's this ill-defined kind of erythematous xerotic patch that's very itchy. And the reason I think, this is nature's way to keep molluscum going. So each individual molluscum lesion has a little white viral particle within it. When it causes the dermatitis is really itchy. Kids are itching it, and they're spreading that viral particle to other parts of the body and causing the molluscum to infect other parts of skin. So the dermatitis is molluscum's way to keep itself going. And in our patients with atopic dermatitis, they get a lot more severe molluscum, a lot more, because that barrier is disrupted of their skin. So, we see molluscum peaking in school age. It spreads person to person by that viral particle touching another person's skin. And so sharing towels. There's been some reports in swimming pools. but oftentimes just direct contact with those lesions is how it's spread. It actually self-resolves. So if we did nothing, it would go away. But sometimes it can take 4 months to several years, and can be really kind of distressing. How do we treat molluscum? Pretty much everything you can think of. And the goal is to cause irritation. So the immune system comes and recognizes the molluscum. In the clinic, we freeze molluscum. There's actually a blistering beetle juice called cantharidin that was actually just FDA approved, and can be applied to the molluscum lesion. We don't have it in our clinics yet at Seattle Children's, but it may be coming. I've heard apple cider vinegar. There's over-the-counter Zymoderm, which is an iodine-based medicine. Our imiquimod, which is used for genital warts, can be used, has been thought to be used for molluscum, but actually research has shown that it's been not as effective. But anti-acne medicines such as tretinoin can cause that irritation to the molluscum lesions, try to get the immune system to come and recognize the molluscum lesions so that they resolve faster. And then this is a kind of a cool phenomena that can happen with molluscum. So if this patient came in to see me, I could identify that this is molluscum because there's these pearly papules. Here you can see that viral particle, that little core of the virus kind of protruding out. But you see some of the molluscum lesions are really inflamed. And this is called the beginning of the end sign, the boat sign. And it's actually a predictor that the immune system has finally recognized these molluscum lesions and caused inflammation, and these are about to go away. Many times this gets mistaken for infection. Patients get antibiotics, but oftentimes if you did a swab of these, there's no bacteria there. It's just red from the inflammation. So if I see this sign, I tell parents that, the molluscum is starting to be recognized by the immune system and should start to go away. Okay, so we talked about infection. Now, moving on to kind of the fourth pillar of atopic dermatitis. Atopic dermatitis is really itchy, and that itch scratch cycle continues to propagate it. And so antihistamines are really important. Itching oftentimes is worse at night, and that's because kids are less distracted, and the way our skin kind of regulates ourselves, we can release certain kind of catecholamines and things that can drive itching. And so sometimes a nighttime sedating antihistamine can be helpful, such as Benadryl or hydroxyzine. Use of non-sedating antihistamines can also be helpful, such as cetirizine, especially if they have seasonal allergies. And that really helps break the itch scratch cycle. If we're not able to do this, oftentimes then oftentimes we can't fully treat the eczema. So that's one of the management strategies in addition to emollients and anti-inflammatories. And then this is something that I really love using, wet wrap treatments, especially at nighttime. And what wet wrap treatments is kind of like a soak and smear. We have the patient bathe. We have them put medicine after bathing on all the active areas of eczema, and then a really thick emollient, such as Aquaphor or Vaseline, and cover themselves kind of head to toe with it. Then take 2 cotton pajamas, dip one in warm water, wring it out so it's barely damp. Put that damp pair of pajamas on top of the medicine and emollient, and the dry pair, and then a second dry pair on top of that, and have a patient sleep in it. The little bit of moisture actually drives the medicine into the skin better. You're kind of creating like a tropical moist environment to help the medicine drive into the skin better, open up those pores, and also provide a barrier for the patient not to be able to get to the eczema lesions and itch them as well. So this is a great technique. I have patients use this overnight. If they can't use it overnight, even a few hours in the evening can be really helpful. Sometimes patients have really stubborn areas on the like dorsal hands, on the dorsal feet. They can do a modified rep wrap just with cotton socks. So same idea, but just localized. They don't have to do full body if they don't have eczema covering everywhere. So really wonderful. If you look on our Seattle Children's website, there are great patient handouts. You can access this even if you're not in child or in our system. There's great handouts on bleach bats as well as wet wraps. And then lastly, just explore any barriers patients might have in being able to complete all of these different things to treat eczema. Transportation, food insecurity, um, cultural thoughts or norms that might keep them from treating the eczema well. I have some of my populations that think that eczema comes from being from dirt. And so they're oftentimes like trying to scrub the eczema and really trying to keep it clean, which actually propagates the rash. And then other kind of cultural practices using different herbal techniques or essential oils, things that might be irritating to the skin. So really exploring all those other barriers that might keep you from treating eczema well. And then concluding with our last chapter, so an outside job. So this is, I have a very similar patient to this with atopic dermatitis who everywhere else on the body, we could get their atopic dermatitis to clear, but right around the mouth and right around the anus, we could not get it to clear. They were 10 years old, using topical steroids, kind of mid to high potency, using antibiotic ointments, emollients, but in these areas, they just did not clear. And upon further questioning after a few visits, we realized that this kind of elementary school kid was actually using wipes, diaper wipes, to clean hands after meals, wipe the buttock area after going to the bathroom. And a lot of household regular products have contact allergens. And there's actually a whole society that has an Allergen of the Year award every year, which is, quite hilarious. But the one of the allergens that we see quite often is preservatives. And so diaper wipes actually have this preservative, methyl isothiazolinene, that's really common ingredients in wipes and can lead to increased irritation and contact dermatitis. So if you have a patient that has kind of refractory eczema, not getting better, kind of delve into things that they're using. And he didn't really think much of these diaper wipes. He thought of them as pretty innocuous. But we also see it in patients with diaper dermatitis. Water wipes or water-based wipes, or even just a cotton cloth with water are the best to wipe diaper areas with if they have irritant dermatitis. So be aware of these preservatives. They're everywhere. They're in shampoos, lotions, a lot of household products, and can be really a cause of a lot of persistent dermatitis. These are just some things that this methyl isothiazolinene is in. It's in a lot of just Target brand, Pull-Ups, Huggies brand, Walmart brand, a lot of different things that you wouldn't necessarily think of. So look at the products and look at the ingredients. And here's this patient. We did a patch test. We found that they were positive to that preservative, and once they eliminated the wipes, completely clear. I just wanted to bring some other outside jobs that we will see in our patients. What do you think this patient could have this rash to? Anything that might ring a bell? This is on the kind of back of the upper arm. This is a teenage patient that's seen in our endocrine clinic. So I see some thoughts for ringworm, which is a great thought. It's kind of annular. With ringworm, we oftentimes see the scale on the outside that's advancing to the normal skin. I see some for adhesive and one for a insulin pump or insulin sensor, and that's exactly right. So this patient had a diabetic glucose sensor, put it on the upper arm, and got a contact dermatitis to the adhesive. Here we can see that beautiful bandage sign. So the adhesive to bandages are really common for patients to get contact dermatitis to. Um, this patient has a central line, and again, we can see that adhesive. So this kind of square-shaped rash, and it's very, very weepy and kind of vesicular. Um, and here we can see that again. So this adhesive was over this area. Again, we can see these vesicles develop. Sometimes the contact dermatitis can be really exuberant and cause a lot of vesicles and bulla. It can be mistaken for infection. And so recognizing a contact dermatitis is really important so that we can change the site of adhesive. We can treat the areas that are getting the dermatitis and really address those issues. And, there's some question about long-term topical steroid use. Usually we use topical steroids, use it for 2 to 3 weeks at a time, and that hopefully should take care of the rash. And then taking at least a 1 week break so the skin can kind of get some time without topical steroid. And then this is back when we used to have flip phones. 3 patients that developed this persistent refractory rash due to the nickel in cell phones. And here we can see the old flip phone that might be coming back a little bit, but a nickel allergy. Anyone know what this might be due to? So this image popped up on a mom's group or a parent group, and this patient had a reaction to the dye in tagless T-shirts. So, a lot of baby onesies will have the, size written on the back of the collar, and the dye can be a cause for contact dermatitis. And then any thoughts what might be happening here? Here we're kind of seeing these like drippy, kind of red-brown, linear streaks. This was on the leg, on the upper thigh, on the back of the hand. We're kind of seeing these smear kind of fingerprint-like marks. And I have some thoughts about clothing seams, which are good thoughts, tight-fitting clothing. So this patient had all of these areas involved, and upon further questioning, they were out by the pool a week ago having some lemonade, and parents were also squeezing some limes and lemon for some lemonade and limeade, and had something called phytophotodermatitis. So when you get an area of the skin exposed to limes or lemons and then sun, you can get this dermatitis. It can cause a vesicular kind of erythematous rash kind of in the areas where the lemon juice is touching. So it can be like thumbprint-like, it can be streaky, it can be drippy, and so another outside job. So other plants can also cause this, not only limes and lemons, but parsley, celery, carrots, figs, wild parsnips. Though exposure to those on the skin plus sunlight gives you phytophotodermatitis. And then a couple of things I want to highlight for all those parents and everyone that's seeing kind of kids in the clinic or in the hospital. Homemade slime is all the rage, and actually one of the newest causes of irritant and allergic contact dermatitis. If you look at the ingredients of homemade slime, pretty much every ingredient has something that can cause an allergic contact dermatitis or irritant contact dermatitis. So we're seeing a lot more hand dermatitis in the clinic as well. And then there's also these social media challenges that are out there. So there's a salt and ice challenge, which patients put salt on the skin, then put ice cubes on the skin, and it causes basically almost like a burn on the skin. So if you're seeing these geometric shaped rashes, erosions, ulcerations, think about these social media challenges. There's the Kylie Jenner challenge where you suck into a bottle and cause basically a petechial eruption around the lip. I've seen a patient just yesterday that came in with this rash and was doing it with a Gatorade bottle, kind of sucking in and developing a rash around the lip. The erasure challenge, where they sometimes do say the alphabet while rubbing a eraser on the skin, gives you these linear erosions and abrasions. And then the deodorant challenge, where they take a aerosolized deodorant can and try to um, kind of say the alphabet or sing a song while um, spraying their skin with deodorant. This can cause a big ulceration. Um, so when you're seeing these geometric shaped, isolated, localized rashes, or rashes that don't respond to the treatments that we're thinking about, odd distributions or shapes, then be a good detective and think about outside jobs or contact dermatitis. So that concludes our book today and our chapters, and I'll open it up to questions and try to monitor the chat a little bit too. If you have questions, feel free to maybe unmute yourself, or I'll pass it over to Mindy to help facilitate.
You have tons of great questions. A few were, what is the difference between atopic dermatitis and eczema?
Yeah, so they're actually very much the same. I think eczema is kind of more of the colloquial term. Eczema can be a little bit non-specific in the sense that it's kind of a more blanket statement for dermatitis or inflammation of the skin. And atopic dermatitis kind of really hones in on the fact that the immune system is also causing some of this dysregulation, but they're really the same and can be used interchangeably. And atopic dermatitis is probably what we use more in our medical lingo, but patients might more use eczema.
And another question, excuse me, is I have to use the skin protective wipes often used with ostomy appliances before applying my sensor because of adhesive. And it goes on to say the sensitivity isn't severe, but are there other options?
Yeah. So I would the ostomy sites is really common for us to get irritation around for couple different reasons. One, the products used, two, the adhesive from the ostomy itself, and then sometimes there can be a little bit of leakage of the stool and the contents around the site. So all causing like irritant dermatitis or contact dermatitis. Um, I would kind of explore some other kind of adhesive wipes that you can use. And then sometimes use of topical steroids, either like fluticasone, which comes in a solution, or a spray. You can sometimes put that on, let it dry, then use your adhesive wipe. And the nice thing about that product is that it's not greasy like a ointment or cream, and so then your ostomy will stick to that area. So I would maybe explore with your team if there's any products that they've found helpful, and then always have a little bit of that topical steroid on hand for if it gets really irritated to help decrease that inflammation.
Thank you. Um, this one comes through asking, what would you say is the most common PCP referral to your derm clinic?
Yeah, we get a lot of referrals for eczema, for atopic dermatitis, and so and then also acne. Um, we see a lot of acne as well, and psoriasis and molluscum.
Right. This one comes through an interesting question. What would be the best way to speak to non-medical school staff about how to differentiate, excuse me, between a skin rash that is likely versus one that is not?
A skin rash that is.
So that
Oh,
was me. I'm a school nurse, so I constantly see kids coming into the health room with rashes. And of course, the school staff freaks out because they're like, "Oh God, it's infectious." And so uh yeah, so I am constantly trying to figure out how do I talk to them about when to freak out and when not to, because their knee-jerk reaction is always send the kid home. But I also am trying to balance between making sure kids aren't unnecessarily missing school instruction versus like obviously we're trying to make sure we don't spread anything for the whole school. But I also don't want to constantly be sending a kid home and missing school if it's not necessarily something that I think is infectious. I'm also not there every day because in the great wisdom of Central Kitsap School District, they send me to 3 different places. So I'm at a different school every day during the week. So, there's that too. But sorry, I know I'm kind of venting a little, but but basically, so I'm trying to figure out how do I talk to people that have no medical background at all about what to do when a kid comes in with a rash.
Yeah,
So
well,
just wanted to clarify the question.
yes, thank you so
Yes,
much,
thank you.
and thank you for all of your work in the schools. We really appreciate it. So yes, everything red is not necessarily infected. The key things I would say for like bacterial infections, looking for areas that are kind of that honey colored crust, looking for pustules, looking for kind of expanding redness that might be indicative of cellulitis. The area might feel swollen, red. The child might have a fever. But kind of honing in on those like crusting, pustules, kind of those signs of infection. Um, and knowing that it according to like even the red book, having a bacterial infection is keeping areas covered to prevent spread, and it is not necessarily an indication to always not have a patient in school. Like molluscum, for example, or warts are viral infections, but they don't necessarily need to be taken away from school. But honing in on those kind of features of impetiginization, pustules, expanding redness.
And I think
Thank
we have
you.
time for maybe one more question, if that's okay, Dr. Gupta.
Yeah.
Last one. Can adults experience psoriasis in the genital diaper area even if they do not wear adult incontinent products?
Yes, yeah, they can. There is a variant of psoriasis called inverse psoriasis that adults can get, and it basically hones into all of the intertriginous areas and the genital area. The case that we did just highlighted that sometimes psoriasis can present first in the diaper area in infants because of friction and trauma, but you can also see psoriasis in the genital area throughout life, even without that friction and trauma piece.
Excellent. Thank you so much for answering our questions. And I have kept track of the questions that have come through and requests for maybe some additional resources. And I will work on combining a list for everyone and sending that out sometime next week with some follow-up. And I'm going to turn it over to Ashley momentarily. And again, we want to thank Dr. Gupta. I appreciate you being here.
Thank you. Thank you so much for having me. Have a wonderful day.